Takotsubo cardiomyopathy, also known as stress cardiomyopathy or apical ballooning syndrome, is a heart condition often preceded by a stressful event such as a death of someone or a recent traumatic event. The term Takotsubo is taken from the Japanese name for an octopus trap, which has a shape that is similar to the systolic apical ballooning appearance of the left ventricle. Takotsubo cardiomyopathy is a clinical syndrome associated with reduced ejection fraction of the heart, elevated cardiac enzyme levels, and signs of ischemia on ECG, but in the actual absence of angiographic evidence of obstructive coronary artery disease or acute plaque rupture. The pathophysiology of Takotsubo is unknown. Takotsubo typically occurs in older women and is usually precipitated or triggered by a stressful physical event, such as a fall, motor vehicle accident, as well as an emotional stressful event, such as a death of someone, financial hardships, relationship breakdowns. The postulated mechanisms of Takotsubo include catecholamine excess following one of these stressful events. Recent stresses stimulate sympathetic activity, resulting in release of catecholamines, leading to increased vasoconstriction, heart rate, and contractility of the heart. These changes result in microvascular dysfunction as well as microvascular spasms, and this is thought to result in myocardial stunning. There can also be direct catecholamine-associated myocardial toxicity. And all of these things will essentially manifest as symptoms of heart attack. The other theory is an underlying microvascular dysfunction with coronary artery spasm, again manifesting as heart attack. The typical patient with Takotsubo cardiomyopathy is a post-menopausal woman. Women are much more affected than men, and the risk also increases with age. So these people often present with acute or subacute onset of chest pain and shortness of breath, often with dizziness and occasional syncope. And this is all usually in the context of a recent stressor. On ECG, there are non-specific ST changes, elevation or depression with T-wave changes. Blood tests also show elevated troponins. Because of these acute events, they often resemble an acute coronary syndrome, a heart attack. And so treatment would always be treatment for acute coronary syndrome, and an emergent coronary angiogram is often performed. Angiogram in Takotsubo's cardiomyopathy will demonstrate non-obstructive coronary artery disease. On angiogram, you can also visualize that during diastole, the ventricles are filling with blood, but during systole, the apical section of the ventricular cardiomyocyte is hypokinetic. It's not really working. And this is the most common form of Takotsubo cardiomyopathy. So by using an echocardiogram, you can also see features of Takotsubo. There's systolic apical ballooning appearance of the left ventricle, and this is the most common and typical form of this disorder. There are other variants. You can have apical portion of the ventricle being spared, or you can even have one segment that is affected. This is far less common. And remember, these ventricular wall motion abnormalities is not a result of coronary artery disease. So the diagnostic criteria for Takotsubo is 1, there is no angiographic evidence of coronary artery disease or acute plaque rupture. 2, This is only a transient regional wall motion abnormality, typically with not a single coronary distribution. 3, there are new ECG changes with modest troponin elevation. And 4, there is absence of pheochromocytoma or myocarditis. Once Takotsubo cardiomyopathy is diagnosed, treatment is largely supportive and is similar to that for heart failure syndromes, ACE inhibitors, beta blockers, and diuretics. Most patients will recover cardiac function over the course of a few weeks to months. As with other forms of new onset heart failure, repeat echocardiography should be performed in 3 to 6 months to evaluate recovery. The duration of medical treatment depends on each clinician, but typically up to 1 year.